We've got Bharath Lakkappa, who's a consultant geriatrician from Northamptonshire, and Ben Owen, who's an ED consultant from Sherwood Forest Hospital in Mansfield. So these two have done a double act for as long as I've been in ESIST, and I've seen them many times talking about this particular subject, and it's how we embrace risk. But I've asked them this time to think about how we embrace risk over the COVID era. When we first thought about this was before we started seeing the increase in numbers, so it was more of a reflection. But now it almost seems like more of a perspective view as well as we move forward. So I'm going to hand the floor over to these two, because I know they're going to fill the session very well. I'll keep an eye on time, but Ben, Bharath, over to you.
Thanks, Nick.
Thanks, Nick. I said we wanted to talk about first of all why this matters. I think in emergency care and also obviously COVID is particularly high risk with the frail elderly. Bharath's a geriatrician, I'm an ED consultant, and crowding in EDs, crowding in hospitals, excessive length of stay has always had a risk for patients. That's never gone away, and risk of admission, there's a risk of other hospital infection, there's a risk of deconditioning, and all those things have always mattered to frail old people particularly, but to all patients. All that COVID's done is made that worse, and actually, so it's meant that we have to manage our patients' risks even more clearly and more carefully. And the fact of the matter is, and I talk to my staff now and say, for every frail old person who gets COVID through admission to hospital or through contact with a healthcare professional, 1 in 5 will die, and that's a really powerful message. And actually, doing our job well and managing them and what their expectations are and being honest with them is always important. That's just even more important now. And Bharath's got a statistic around hospital-acquired infection as well as to why this is so important.
It's really scary for the only reasons is we're seeing these tier 3 and then local lockdowns. But one of the statistics which came out most recently, I think it was a week and a half ago, was 25% of the COVID infections of the frail elderly was actually acquired in hospital in Wales. So that's really a scary number. These patients came in for different reasons, but because of the frailty and increased risk, they seem to have acquired COVID in the hospital. And that's the statistics, Ben, just to add to what you were talking about before.
Cool, thanks. And we want to talk about how the language we use is really important. And there's risk everywhere you look. There's not, people talk about, I want my ward to be safe, my hospital to be safe. And actually, we can't promise safe to anyone, because there's a risk in everything we do. There's a risk in coming to hospital, there's a risk in not coming to hospital. And actually, this is about, there is no safe, there is no risk scenario. This is about a balance of risks. And that balance of risk is different for every patient and for every situation. And that will change depending on what is wrong with them. And actually now, even more so, probably that will change depending on the level of COVID in the community and the hospitals. And therefore, we've got to do that. We've got to talk to our patients. But it's the concept, actually, we just think slightly differently. We're very good in healthcare at talking about, is it safe or not? And that question there isn't really a sensible answer to that. It's actually about, is it a low risk, medium risk, high risk scenario for the system and for patients? And really about this is about in urgent care, the risk of cross transmission is really around your attention to detail around PPE and seeing people you have to see, but also not seeing people or doing things you don't have to do, and that's a balance now we have to strike. But also it's the thing of crowding is a real risk, both in emergency departments, in care homes, and also in inpatient beds. And actually, it's about thinking about how we do our job in the most efficient way possible, how we minimise admissions, and that's becoming even more important, how we minimise the time people spend in emergency departments. Our pathways are working well, but also in inpatient beds. Thinking, can this be done in the community? Can this be done, if they are admitted, can they be managed within a couple of days in the community? How do I identify those for early discharge? And we saw with the first lockdown how everyone had, we managed to empty the hospitals quite quickly. We also saw rampant transmission within care homes at times. And we don't know the answer to all those questions, what is right and wrong. We do know that crowding is down to two things: how many people come through the door and how long they spend in any given area, like an emergency department or a hospital. So you can do two things: you can reduce the number of people coming in an appropriate way, and you can reduce the amount of time they spend in there. other than that and your PPE. What community approaches would you look at, Bharath, in terms of admitting people or deciding around frail elderly in hospital?
I mean, there are two things. For us, when you look at a frail elderly person coming in, we just need to understand the reality of the situation right now. When they come into the hospital, we are talking about people in masks. They're in space like gowns. Some of them have got respirators on. Some of them also have visors on. And these are frail elderly. Around about 1 in 5 of 85 plus will have some kind of mild cognitive impairment or neurodegenerative condition. So these patients instantly can't hear, can't look, they can't see, and they're scared. And it starts coming up as when you start taking history, if they can't hear you, the confusion increases. So instantly the patient is classified as delirium or confusion. Bit unfair. So the next risk when you look at the patient, that if you think it's safe for the patient because there is some element you want to keep them in, if there's necessity, that's fine. If you don't think there's necessity, the falls risk increases just by getting into the hospital. The other thing for them is the minute they're admitted for more than a day, their risk of falls increases when they go back home as well. So it doesn't really stop at just admission being safe. The fracture neck of femur risk increases because most of the falls which happen in hospital, 50% will have fracture neck of femurs. And then when you look at what we're going to be doing if the patient doesn't need to be in hospital, is we keep them in bed for nearly 93% of the time they're there. There's lots of gyroscopic studies which have shown that patients don't mobilize or they just plain horizontal in bed. So before we send somebody in, I think we do need to think of the risks of deconditioning and other things for them. The element right now, what we face is patients are refusing to come in as much as we can, but we use guidelines similar to everybody else, and use two for sepsis or patient has got fast or chest pain, and if they're really appropriate, then we do take that call of getting them in. The biggest aspect for us is if we are asking for tests to be done and then being brought out, if they don't come out, then they get sucked into the hospital system, and the difficulty they face is getting out of the system there. That is one of the big risks we face. Then the other thing is them being informed about the risk is quite important. How do we get them to understand the risk is where the A&E folk come in, where you are able to explain to them, or people need to understand, are they really informed about the risk of an admission?
Bharath, I think
you can
lost. I think his connection's just dropped out, so I'm just going to make him a co-host again.
Okay. To the point of how do you inform the patient of admission avoidance risk when they come into hospital? Because we do send some patients in to get investigations done, and then they need to come out as soon as we can. But people need to be informed of the risk. As you rightly said before, there's no safe risk or no risk. So how do we go from there in the A&E?
I think Ben's having a bit of trouble.
That's okay. I can continue with a few things which we discuss and review with.
Yeah, Bharath, so you've asked a question, so I'm going to sort of bounce it back to you. Have you got any thoughts on that in particular?
Yes, absolutely spot on. I mean, if we think of admission avoidance as admission avoidance, I think it's a bit unfair term. The main thing we need to discuss is whether the patient is getting the best out of what we are trying to look for. Are we trying to make them safe in a way that they can function and then be more independent? So we simply ask a few questions. So if you're an A&E doctor or a geriatrician, or if you're anybody in the ward junior doctor, you got to ask simple questions. The simple questions you usually ask is the activities of daily living recoverable, or is it need some assistance, and can that be done at home? That should be one of the first questions, because eating, drinking, washing, and able to mobilize to the toilet, if they can do that, they should be doing it at home. Second aspect we look for is medication and meals. We try to keep it as simple as possible and to eliminate risks for these patients. So if they can take the medications, if there's help from family members, neighbors, especially in COVID time, you get unlucky if they can't mix in households. So that's a different change we can look at. Telephone advice from family members. We can ask people to call in to see if they're taking the medications. The other aspect is if there is sufficient and willing caregivers. Families have made bubbles now, so if they can help out the patients at home, that should be thought of prior to anything else. The biggest thing, everybody works about is the safety at home. I mean, what we need to understand is we got patients' family members who know them for a long time, a collateral history of saying the safety. But it's a bit unfair to say somebody's not safe at home if somebody's 98 and they've lived there for 50 years. They've been safe for 50 years. So what else can we add to or decrease their risk? I mean, they've been living. Some people even walk up and down the stairs on their backside, which if you ask him how many years have we done, yeah, 22, 23. The last one was 15 years. And you wonder where the calluses came from. So I think asking and talking to the patient is a starting point. And the other aspect is, yes, we do require to make that assessment is really home monitoring required. Does a nurse need to go in? Okay, if they want to do their blood pressure checks, or do you think that the chest infection is clearing up? Or if in some places where we have oxygen saturation sent out, just in case they came with the infection, they're negative for COVID on the swab, but they still could be the true false negative, so they can go home with saturations and then can be followed up. Do they need the physiotherapy, occupational therapy if they're false patient, or if there's any rapid response social care? So we can do all those asks to yourself first, and then look at the patient in front of you, and then ask if the patient is safe actually to come in. Are they actually safe to go home? And that should be one of the biggest questions you ask yourselves. The follow-up with primary care, it's easy to say you need follow-up for primary care. It's easy to say we need blood tests, but is it going to add value to the patient? The difficulty is if you want blood tests to be done right now, patients don't want to go into hospital to phlebotomy. Some phlebotomy places have got change procedures. If you're going to send a district nurse, community nurse, or phlebotomist in, do you really require that patient to be exposed to that risk of a healthcare professional? Those are the simple things we can ask ourselves. And those are the things I would ask myself, and that's what we do in our training and teaching our staff over here. But how do you implement that for each patient is actually explaining the risk to that patient. If they can be done at home, they're better off at home. That's what I would think, and that's how the thinking should be, Nick.
I think Ben's back on now. Did you want to pick up any of those?
Yeah, thanks. Apologies for that. This for me is looking at also people that do need to come into hospital. It's how we do it in the best possible way. So we shouldn't hold people in emergency departments pending COVID swabs and things. The longer they stay in their ED, the greater the risk of nosocomial infection. If you infect within your ED and you bring someone into the hospital, then actually what you're doing is seeding the whole hospital. So it's really important we have pathways that get people through the emergency department quickly. We get people through on pathways that work quickly. We don't hold people for unnecessary reasons. We don't use ED when we don't need to. So it's making sure those that come in when they're ready to go in, they come in. If there are other pathways in, other specialities don't default to ED. So this is all doing the basics well. Your internal professional standards, making sure people see the right clinician first time. It's just becoming even more important. I think access for emergency departments and other specialties to specialty advice has been shown to both reduce admission but also reduce length of stay. So getting someone in the right bed first time and actually getting senior involvement early on, making sure people are seen within a timely fashion, particularly by consultants when admitted to hospital and seen on a daily basis, and there are clear plans that are around planning for discharge from admission. It's not a complete surprise. It shouldn't be a complete surprise on the day of discharge that someone needs some other social care input. It's usually pretty obvious from the very start. So planning that stuff from the day they arrive to hospital can make a real difference to people generally, but particularly more so at the moment. And I think it's how we escalate that, it's how we challenge each other. What COVID did show is how well we can work together as a system. And actually part of this is how we seize those good things, that goodwill, but also how we seize those good ideas and things that work really well in COVID, that speeded up flow, avoiding admissions, that they carry on. If it worked well in COVID, it's probably something we should keep doing full stop. We don't stop doing it because there's no longer a lockdown. If it was good for patients, out of adversity comes opportunity, and there's opportunity here to improve our processes even more. The key thing is how we tackle each other as well. So people saying things like, I'm risk averse, or it's not safe to admit that patient to my area unless I know they're a negative swab. What you're really saying is, someone saying that is actually saying, I'm happy for that patient to sit in the area you're in and risk cross-facing the other patients, but not my patients. We're all responsible for all our patients and all our actions, and that's never changed. But saying, I'm not bringing them in yet until I've got a negative swab for this area, just means they're sitting in another area. If they're positive, they're positive. And actually the risk of cross-infection is the same wherever they are. So you're not reducing that patient's risk, and you're not reducing other patients' risk by holding them somewhere. If they come into your ward, we need good processes and good things to get them into hospital. And we need to work together. Likewise, when we're discharging people, we really need to work really well with places like care homes and care agencies. When we're getting people home, it's communicating those that are positive and negative for COVID really well with the care homes. It's about making sure that when they do go back to the care homes or into other ward areas, we know who's been swabbed, who's not been swabbed, and actually making sure we don't make mistakes like someone has a positive swab in the community 3 days earlier, then has a negative swab, it doesn't go down. Oh, they're negative. Actually, well, if they've been positive once, we have to assume they're positive now. We can't make that thing. So again, it's a lot of, this is about, again, attention to detail and really good communication. And it's how we can improve that communication between the hospitals and community on discharge, and also for mission avoidance. Any further thoughts on that, Bharath, on how we can improve discharge coordination?
I think the biggest fear everybody is that if they go home, they won't be reviewed. But you do have community services nursing, and patients can be reviewed according to their needs. Some places also are using oxygen saturation pulse oximeters as well. So the residential nursing homes, better coordination with their advanced care planning, which has already been in place, and if possible, getting the palliative care teams involved. If you think that the patient is extremely frail and they've already got an advanced player, an escalation, a ceiling of care. So I think it's a little bit more talking to. We did it amazingly well in the start of COVID, and I think we can still do it. We can. I think the difficulty we face is we are looking at risk in a different way. We're not looking at risk for that patient. Admission, if it's not necessary, it's much, much more riskier than admitting them. So the frail patient, as you rightly said in the very beginning, 1 in 5 has a chance of dying from COVID if they come in. So that is where we need to be thinking of, is if they don't need to come in, what else can we add in the community? But keeping to the basics, asking them if anything is needed in the community, if we can, that'll be fine. But majority of the time we fail to ask their own family members who can help, and that might be the first step we need to do.
Bharath, Ben, I'm just going to jump in. We've got 2 minutes left before we have to hand back to Pete. Fascinating discussion, and this is something that we've talked about a lot before, and a lot of interest in. Is there anything, from either of you, just final words to leave people with? Any messages you want for people to take away?
I mean, for me, it's that thing of whatever we do for one individual patient affects other patients as well, and actually holding people up in the system who need to come in is never beneficial to usually the other patients or that patient. Likewise, admitting someone who perhaps didn't need admission is usually never beneficial to that patient, and certainly not beneficial to others. So it's have that wider system view, and I think it's talking to patients about the risks. We talk about the risk, we worry about the risk of discharge, we don't talk about the risk of admission. And honest conversation with patients usually comes to the right outcome. And better communication between care homes, hospitals, community teams will always lead to better outcomes for patients and better decision making. So, and just do the basics well.
Brilliant. Yeah.
The biggest,
advice.
the other risk. Sorry, Nick. Last one sentence. The other risk is patients right now, when they're admitted, they don't have any visitors. Psychologically, they are really, really poor with the support network. I mean, patients with dementia, they can't have any visitors as well. So I think risk of admission needs to be really weighed in, and the risk for that patient, not for the risk for the system or for the A&E or for the unit which you're, or for yourself. It should be put across as a risk for the patient.
Brilliant. Thank you, guys. That was a really interesting short chat, and we have got some videos on our YouTube channel with these two guys talking more about embracing risk, and I'm sure we'll get them back again for another chat, and a bit of a longer chat next time. But thank you, guys. Really appreciate your time. I'm going to hand back to Pete.